Now we will talk about a common reproductive endocrine topic, primary amenorrhea. The incidence about 3% in general population. Definition: absence of menstruation, never menstruated before. We start investigation at the age of 14 years if there are no secondary sexual characteristics, or age of 16 with any secondary sexual characteristics. Pathophysiology: anovulation, ovarian, gonadal failure, pituitary, hypothalamic, which is considered as a higher center defect, characterized by low FSH and LH, while ovarian characterized by high FSH, hypergonadotrophic hypogonadism, and higher center characterized by hypogonadotrophic hypogonadism. Amenorrhea secondary to systematic disease or anatomical might be a severe form of anatomical disorder like uterine agenesis, like in Rokitansky syndrome, or an simple condition like imperforated hymen that represent outflow obstruction. Clinical evaluation involves history taking, examination, arranging investigation. So, history, you need to take an history of chronic systemic illness such as diabetes, cystic fibrosis, renal failure, any history of delayed puberty in the family, mother and siblings, to rule out constitutional or to confirm constitutional or familial primary amenorrhea. Any symptoms suggestive of higher center defect like anosmia or hypoosmia, reduced or absent sense of smell, which is suggestive of Kalman syndrome. If she has any history of excessive exercise or competitive sports recently, anorexia nervosa, childhood cancer requiring chemotherapy or radiotherapy as both toxic to the human gametes, the sperm and the egg. In 50% of the cases, this will lead to gonadal failure, testicular failure, or ovarian failure. Any cyclical pelvic pain that presented usually after the age of puberty, which is suggestive of outflow obstruction, especially in imperforated hymen and vaginal septum or cervical agenesis. Examination. In the examination, we need to focus on the stature. We need to assess her height. If she is short stature, might be due to Turner syndrome. If she is tall, might be a Kalman syndrome, or if her height is normal. PMI, very important, as low PMI associated with hypothalamic amenorrhea, or if she is also obese, this is also suggestive of polycystic ovarian syndrome, hypothalamic pituitary ovarian dysfunction, not failure, dysfunction. Breast development, which indicates estrogen level in the blood and the ovarian function. Normal breast development indicates a normal gonadal function, and absent breast indicates gonadal failure. And we classify we score the breast according to Tanner stage. Tanner 0, absent breast; Tanner 1, budding; Tanner 2, small breast tissue; and 5, fully matured breast or adult breast. Presence of pubic and axillary hair, inguinal masses to rule out presence of testes in certain syndromes that may cause primary amenorrhea in cases of male karyotyping and female phenotype. Presence or absence of hirsutism and virilization. All these clinical signs we need to look for. To identify the cause, is it higher center, is it a gonadal peripheral, or is it anatomical? We need to arrange blood tests and imaging studies, pelvic imaging studies. The blood test, the first one is endocrine profile, FSH, LH, and estradiol. If all elevated FSH and LH, this is an gonadal failure. Okay, if FSH and LH low, less than 1.2, we call them undetectable. Okay, less than 1.2 international unit per liter, this is a higher center defect, hypogonadotrophic hypogonadism. But as I said, if they are high FSH and LH more than 20, 25, okay, this is a hypergonadotrophic hypogonadism and gonadal failure. E2, it will reflect the ovarian function. If FSH and LH high, that goes with gonadal failure, we need to assess peripheral blood karyotyping to rule out certain syndromes. Pelvic imaging studies in cases of syndromes and in cases of anatomical disorders. Approach. The presence or absence of secondary sexual characteristics along with gonadotropins, FSH, LH levels help make an initial assessment of the possible causes of amenorrhea. Normal breast development usually indicates that there is a normal ovarian function or that there has been at some point. So low gonadotropin, as I said, the defect in the higher center, hypothalamic or pituitary failure or dysfunction, while high gonadotropins, high FSH, LH, this is a gonadal failure. Normal FSH, LH, normal gonadotropin, usually anatomical disorder. How we can identify the cause? A girl with primary amenorrhea falls into one of the four followings. The first scenario, absent breast development and low FSH. So there is a higher center defect, hypogonadotrophic hypogonadism, as a sequelae of low FSH LH. There is no any ovarian function, so this will lead to an hypoestrogenic status that prevented the development of the breast and the growth of the uterus. So she will end up by delayed puberty associated with primary amenorrhea, or might be an benign condition, constitutional primary amenorrhea or a familial primary amenorrhea. The second scenario, if the breast absent and FSH is high and LH also is high, this indicates an agonadal failure. So the defect lies in the gonad, which has no hormonal or reproductive potential. We need to do immediately an karyotyping. Why? To rule out Turner syndrome or Sawyer syndrome. Turner syndrome, you know, it's a female karyotyping with a female phenotype, short stature, ovarian failure. Sawyer syndrome, it's a syndrome characterized by male karyotyping, okay, with a female phenotype. Why female phenotype? Because masculinization and development of the external male genitalia, they haven't occurred. Why? Due to lack of testosterone secretion from the abnormal testes. So the Mullerian duct hasn't regressed because the testes not secreted any AMH to regress the Mullerian duct, and there were no any testosterone secretion from the testes. For that reason, masculinization and formation of external male genitalia failed to occur. So this is a male karyotyping with a female phenotype. The third scenario, normal breast development and high FSH. How this will work? It doesn't work unless if the puberty arrested at certain point. So we need to do karyotyping and pelvic imaging studies to differentiate between two conditions. Premature ovarian failure that has a normal female karyotype 46XX, uterus is present, or a complete androgen insensitivity, a male karyotyping 46XY, there is no uterus, and absence of pubic and axillary hair, which are androgen dependent, and short vagina. Why complete androgen insensitivity? They have a female phenotype because the testosterone, it was secreted normally from a normal testis, but the defect lies in the end receptors. The end receptors for the testosterone, it wasn't working. Why? Because there was a sensitivity to testosterone. So we call it complete androgen insensitivity. testosterone to act and to be a potent form, it needs to be converted under the effect of the enzyme that called 5-alpha reductase to dihydrotestosterone at the end receptors. If this not occurred, okay, so the testosterone, it will not act. For that reason, such a group of patients, they have a failure of masculinization and a failure of development of the external male genitalia. How we can differentiate between complete androgen insensitivity and Sawyer syndrome? Sawyer syndrome, they have a uterus. Why? Because the testes were not functioning and not secreting at that time AMH to regress the Mullerian duct. Here, the testes normal and functioning, and they secreted both AMH and testosterone. AMH has worked, testosterone hasn't worked. Why? Because the defect, it was in the end receptors. The fourth scenario, normal breast development and normal FSH. This is usually happens in cases of anatomical defect. Anatomical defect, we need to arrange pelvic imaging study to identify if there is any Mullerian duct or absence of the Mullerian duct. Complete absence of the uterus, like in Mayer-Rokitansky-Koster-Hauser syndrome, they have just pure gonadal, just pure uterine agenesis, not gonadal, just pure uterine agenesis. They have no uterus. وهذول هم الحالات اللي بنعمل uterine transplantation. إذا سامعين في حالات successful worldwide, okay, ماشي, and delivered, okay, هم حالات, they are the Rokitansky syndrome, that they have pure, okay, uterine agenesis, absent uterus just. Or obstructive anomalies, imperforated hymen, vaginal septum, vaginal agenesis, cervical agenesis. From obstructive anomalies, the most easy one to treat and to present, it is imperforated hymen, usually presented with primary amenorrhea, associated with development of secondary sexual characteristic, and associated with cyclical pelvic pain, and might be severe enough to cause uroretention. What is the cause of cyclical pelvic pain? It is the menstruation. She menstruated, okay, but there is no passage for the menstrual blood loss. The blood will accumulate in the vagina, causing a condition called hematocolpus, and she will menstruate every cycle, so the blood will accumulate more and more, and it will lead to hematocolpus. Then it will go up to distend the uterus to cause hematometra. Management, it depends on the cause. Anatomical, correct the cause. Imperforated hymen, do crochet incision, okay, to allow for the passage of the menstrual blood loss. Septum, excise the septum, okay. Rokitansky and complete androgen insensitivity, unfortunately, okay, there is no successful treatment rather than psychological support and to expand the vagina to allow sexual intercourse. In case of complete androgen sensitivity, you need to remove the testes as there is a risk of malignancy. What about higher center and gonadal failure? Okay, they have low estrogen level, so we need to do induction of the puberty. We need to give them small doses of estrogen, okay, to grow the breast, to grow the uterus, okay, and to protect against osteoporosis and ischemic heart disease. We start usually by small dose of estrogen, natural estrogen, then will increase every 2-3 months, okay, until menstruation occurs. Once menstruation occurs, then we can give them a full dose of OCP, oral contraceptive pills, till the age of natural menopause, about 51 years old. Secondary amenorrhea, it is less common than primary amenorrhea. The incidence is around %. It is the absence of menstrual period for 6 months in women who had previously been regular, or for 12 months in women who had irregular periods. Any lady should bleed 3 to 4 times per year. You will not allow more than that, aiming to prevent endometrial hyperplasia. Any lady in the reproductive age presented with secondary amenorrhea, you need to rule out pregnancy in the first instance, as the most common cause of secondary amenorrhea at reproductive age is pregnancy. Once pregnancy ruled out, you need now to look for a cause. The cause might be higher center, the cause might be gonadal, or might be anatomical. Higher center might be hyperprolactinemia, or might be an hypothalamic or pituitary failure like a Sheehan syndrome, okay, and treat the underlying pathology, and might be thyroid disease, hypothyroidism or hyperthyroidism. So you need to arrange TSH, T3, T4. And also you need to arrange gonadotropins, FSH, LH, to rule out premature ovarian failure. If they are in 2 occasions more than 25 international units per liter, this indicates gonadal failure and premature ovarian failure. And you can give a progestogen to do the progestogen challenge test to see if this patient adequately estrogenized, okay, or she is hypoestrogenized. Usually we give progestogen, not progesterone because it's the natural one. Progestogen, it is a synthetic one. You give progestogen for few days, a couple of days, 5 to 7 days, then you stop it. If the endometrium is adequately estrogenized and there's proliferative endometrium, you will support, you will organize. Once you remove this support, okay, the endometrium will shed. If the endometrium is not adequately estrogenized, she will not menstruate, and we call it a negative progestogen challenge test. An important cause, uncommon, but it's an important and a serious cause, it is an Asherman syndrome. What's Asherman syndrome? Asherman syndrome, it is an intrauterine synechia. Might be severe enough to cause an infertility, and it may cause an lifelong amenorrhea and lifelong infertility. It depends on the severity and how many percentage of the endometrium affected. The risk factors for having Asherman syndrome: endometritis, infection, okay, and adhesion formation following the infection, any instrumentation, vigorous instrumentation to the uterus like a vigorous curettage, any manual manipulation of the endometrium, any thermal current application on the endometrium that damage the endometrium. As you know, the endometrium 2 layers: functionalis that shed every cycle, and basalis that regenerates the functionalis. So if you damage the functionalis and the basalis layer, you will end up by a scar formation, scar tissue formation. The typical presentation usually amenorrhea or hypomenorrhea. Hypomenorrhea, it means a few drops of blood every cycle. A small amount of menstrual blood loss every cycle. How we manage, how we diagnose? Usually from the history, then we will examine by ultrasound. We will see a thin endometrium in the late follicular and luteal phase, and we will measure the estrogen level, and we can see that the estrogen level is within normal but cannot build up the endometrium. In this case, we suspect Asherman syndrome or intrauterine synechia. Management: hysteroscopic adhesolysis. Risk of perforation is high. Sometimes you need to combine it with laparoscopy. We call it laparoscopic controlled adhesolysis. If you managed to lyse the adhesions, you need to insert a barrier, mechanical barrier like an IUCD or a Foley catheter balloon, to prevent the reconnection of adhesion bands and to give high dose of estrogen to build up a new endometrium.